in this space, we are thinking about a woman who's had a previous Caesar and is now trying to have a vaginal birth after that Caesar. We know that the most worrisome complication of having a vaginal birth after a Caesar is that this old scar on the uterus breaks open. That only happens about 0.5% of the time, but when it does happen, it can be catastrophic for both mum and baby. So that's the thing that we're trying to think about today. With a short gap, so less than 12 months, we have some evidence that suggests that a uterine rupture is more likely. We also know that the evidence suggests that you're more likely to have a placenta that grows in abnormally over the scar. So that could be a placenta that grows into the scar, or it could be a placenta that grows over the cervix as well. There's some evidence as well that suggests that you might have more chance of a preterm birth as well in this setting. So we think, based on the evidence that we have, that 12 months is probably the shortest time interval between a previous Caesar and then trying for a vaginal birth. Really, the key thing is that you have a good conversation about a VBAC with the person who's looking after you in this pregnancy. And it's actually quite a complex conversation, and the birth interval is only a small part of that conversation. I'd really encourage you to have that conversation as soon as you can in your pregnancy, so that you can start planning and working out what you want to do in this second pregnancy. Nausea and vomiting in pregnancy is incredibly common. It's one of the first symptoms of pregnancy, and it might start from 4 weeks, and some women might get a reprieve until 10 weeks. Other women have their nausea that starts at 4 weeks. Most women, thankfully, have had their nausea resolved by about 20 weeks. It's so common. It's about 70% of women are affected by nausea and vomiting. There's a small proportion of those women who are affected by the really nasty form called hyperemesis gravidarum. That's about 1% of women. But look, let's face it, you go from being a healthy, happy individual who feels great most of the time to having nausea almost all day, every day. The term morning sickness, I don't know who came up with that, because having spoken to women for many years now about their nausea and vomiting in pregnancy, it could be in the morning, it could be in the afternoon, it could be in the evenings, it could wake them up at night. It really should be called all-day sickness. In terms of how we manage nausea and vomiting in pregnancy, we've got quite a few options open to us. Whenever we're thinking about medications in pregnancy, we have them categorised. So category A is our safest option for pregnancy. There's category B, which is also safe for pregnancy. So there's category B1, B2 and B3. Then there's category C drugs, which we try really hard to avoid. And then the rest of the drugs we just don't use in pregnancy at all. So the question today was regarding doxalamine, which is also called Restovit. Now, the nice thing about this product is it's available across the counter. I do find though sometimes pharmacists, once they know you're pregnant, are pretty reluctant to give it to you, and so sometimes it is easier to have a script from us. In terms of managing nausea and vomiting, I'd always say it's like a ladder. It's a little bit like the pain relief ladder that I talk about for labour pain relief. But with nausea and vomiting, you should start with your simple things. Make sure you eat small meals often. Try not to get too hungry. If you're too tired, then often your nausea is worse. If you're doing all of those things, you can also add in some ginger tablets and some vitamin B6. So they're all easy things that you can start with at home. If you need to look at more options to control your nausea and vomiting, then doxalamine or Restovit you can buy over the counter. I'd always discuss it with your obstetrician or GP just to make sure that it is a safe product for you. Most women can take it really well. The big downside of Restovit is that it causes daytime drowsiness. So generally what I would recommend to my women is that you take it in the evening just before bed. It will help you sleep and it gives you an all-day effect in terms of managing your nausea. Now the tablet comes as a 25 milligram tablet. I would often say to women that you can take the tablet and cut it into quarters even. Trial it on a day or trial it the night before a day where you're not having to be at work. If you've got small children in your life already, try it on a day that it's going to be a weekend and your partner's around to give you a hand with the children in case you are really sleepy the following day. For some women, a quarter every night is all that they need. Some women use a half, and some women even need a whole tablet. Now, the textbook would say you could take the tablet 3 times a day during the day. I've really not found that that's been a useful way for most women because of that sleepiness that you get with this tablet. So the way it works, it might surprise you, but we've got a area in our brain called the vomit center. Bet you didn't know that. The way that doxylamine works is that it decreases the sensitivity of the vomit center, and so it means that you have less nausea. Now, for some women, doxylamine isn't the complete answer, but it's a good starting point. It's really safe, and you've got control of the dosing. The next options are to look at more pharmacological methods, and that's a conversation that you need to have with your care provider. I get asked this an awful lot. Sleep, you just need sleep, and when you're just about to have a baby, it becomes so important. And the 3rd trimester is often when your sleep is the most disrupted. Why is it disrupted is probably the best question to ask, because if we can work out why your sleep's bad, then we might be able to find a solution, or a partial solution, to try and help correct that. The most common thing that I would hear is the discomfort of pregnancy making your sleep just difficult. We know that your aches and pains in the 3rd trimester, when you're carrying that load of the baby, your posture's changed, your feet are aching, your hips are sore. When you lie down in bed and lay still for the night, those can be aggravated. Women often talk about shoulder and hip pain, and that's related to that pressure of lying on a particular side. Now remember, you can lie on either side in pregnancy. There's a lot of data out there that supports lying on either side. It's not just your left side that you need to lie on, so mix it up. But sometimes just turning over in bed is really uncomfortable as well. You have to wake up almost fully to roll yourself over, reposition with your pillows, your partner gets disturbed. It's just a difficult time to get some decent sleep. The other things that might have effects on your sleep are temperature control. So as you progress in your pregnancy, generally you'll feel hotter and hotter, so you might be disproportionately feeling that heat. So remember, go to sleep in cool clothing, have a sheet and a blanket that you can strip off as required. Lots of women are troubled by reflux. It's often worse at night because as you lie down, your stomach lets that acid leak up into your esophagus, and you might wake up with the pain or the discomfort. So if we can treat reflux prior to going to bed, make sure that you don't eat close to going to bed, avoid those foods that might set you off as well, and treat the reflux before going to bed. I've even heard of some women propping their bed up on an angle so that they don't have the acid coming up as well. You can do that with pillows as well. Sometimes we notice that women start snoring in pregnancy as well. It's not your fault, it's the baby's fault. Well, essentially it's the pregnancy's fault. Snoring is much more common in pregnancy because your airways start to swell even from the very early stages of pregnancy. You're making more mucus secretions, so you're more likely to be obstructed overnight, and so snoring is quite a common feature, particularly in the 3rd trimester. Partners often complain, but sometimes you end up waking yourself up because you're snoring so loudly. It will get better. Once you've had the baby, all of this resolves and things tend to get better quite quickly in that regard. Some women are bothered by vivid dreams in pregnancy. Now, why we dream so vividly in pregnancy is probably related to either temperature control. Sometimes that hormonal change is thought to be one of those factors in vivid dreams. Some women never notice vivid dreams in pregnancy, but some women are really bothered by them. Sometimes those dreams can be quite vivid and nasty, and so that means that you wake up and you're lying there thinking about the horrible dream that you've just had. Some of the other things that can wake you up overnight are baby moving, needing to get up and go to the toilet, and leg cramps or restless legs. I can't do much about your baby moving. In fact, that's great. Can't do much about your bladder other than the simple things of avoiding too much water before going to bed. But let's face it, you're usually really thirsty in pregnancy, so you want to be drinking, you don't want to be dehydrated. In terms of leg cramps though, and restless legs, some women find that some magnesium supplementation is helpful, or restless legs, sometimes women are slightly deficient in iron. They start an iron supplement and they tend to find that the restless legs might be better. So essentially, what can we do to make things better? Well, it's those basic things. Look at your sleep hygiene. So sleep hygiene is related to what do you do just before bed. Obviously avoid your phone, try and read a book, do something that's relaxing that just lets your mind just ease into sleep. Going to bed at the same time, try not to do stressful things just before sleep are also important things. Check in on your mattress and your pillow. Is there anything that we can do to make your comfort better as well? What about the temperature in your room? Could you adjust that? Remember, your poor partner might struggle with a cooler room, but it's a balance. As I said, we can treat reflux, we can treat you with magnesium or iron for leg cramps, and don't forget things like mindfulness or yoga. You don't want to do exercise just before bed, but some mindfulness before bed or earlier in the day, and certainly some exercise in the day can also help you drift off into a better sleep. Do I have a magic solution for sleep in the third trimester? I'm sorry, I don't. But you can think about these things to try and help you get a better night's sleep before your baby is interrupting your sleep. Cholestasis is a pregnancy-specific problem, so we tend to see it presenting in the late second trimester and the early to late third trimester. It's a problem that presents with itch. Now, you can get itchy in pregnancy for a number of reasons. The itch with cholestasis can be quite specific, so we can see it in the in the palms of your hands and the soles of your feet. It can also be a generalized itch. The key feature is that it generally doesn't have a rash associated with it, and when we test your blood, we find that you have increased bile acids. Now, what's a bile acid? A bile acid is something that we all normally produce, and as it suggests, it's in our bile. It's released into our digestive system, and it helps break up the food so that we can absorb it. And it also looks like it's got a hormonal activity as well. And what's happening in cholestasis is that there's an increase of those bile acids that spill over into your bloodstream, and we can measure those with a simple blood test. The proportion of women that have cholestasis in pregnancy is quite variable. There's a lot of research in this area, and some people suggest that the incidence of cholestasis in pregnancy is somewhere between less than 1% right up to almost 30%. So it's a wide variation. We still are learning more about this condition and trying to make this more easily understood for all of us. There are some quite interesting associations known with cholestasis. We tend to see it more in winter in some particular countries. It's also associated with multiple births. Women who've got pre-existing liver disease might also get cholestasis in a pregnancy, but probably the key one is that if you've previously had cholestasis or you've got a family history of cholestasis, then you're more likely to have cholestasis in this pregnancy. Why is that? We think that there's probably some genetic factors that cause women to have cholestasis. There's probably also some hormonal factors. So the way that you are exposed to estrogen and progesterone in your pregnancy, this seems to make some women more prone to getting cholestasis. There also seem to be some environmental factors as well, and that's quite an interesting space in the research at the moment. So if you have itch, we're going to ask you to go and do some bile acid blood tests and also check in on your liver function. So one of the specifics about this question was, why does it affect your liver as well? So essentially, if your bile acids are building up in your bloodstream, it also means that there's a very low level of liver damage in the cells that shouldn't be long term, but we can also pick those up as liver effects as well in the pregnancy. It can affect the liver function as well, so because your absorption might not be as good of the nutrients and vitamins and minerals, we do see a specific thing that's related to pregnancy. You might not absorb your vitamin K that's produced in the liver, and that can affect your ability to form a blood clot. So for some women who have long-standing cholestasis in a pregnancy, they'll be treated with vitamin K just prior to birth, because we know that you need to be able to make a good blood clot when you have a baby. What does cholestasis do to a baby? Well, unfortunately, the bile salts that are increased in your bloodstream cross really readily across the placenta, and they can accumulate in baby. Now, this can lead to preterm delivery, whether that's spontaneous, you go into labour early, or whether, if we know that you've got cholestasis, that we say to you, look, it's time to have your baby. And so there's preterm delivery as one of the risk factors of cholestasis. We also know that babies who have mums who have cholestasis, they have a higher rate of meconium stained liquor. So that's when the baby poos inside of mum, and that can be a problem if baby breathes that in at the time of birth. That can affect the lungs, so we need to manage that birth quite carefully with the paediatricians as well. Babies with mums who have cholestasis are more likely to have respiratory distress as well. Some of that's related to the meconium stained liquor. Unfortunately, and this is the one that worries all of us, there is a slightly increased risk of stillbirth with mums who have cholestasis. Now, our background stillbirth rate is about 0.32%. With cholestasis, the best evidence suggests that this goes up to 0.091%. So it's only a small increase, but any increase is worrisome for both you and for us. We know that the risk of stillbirth increases with the level of the bile acid increase, and if your bile acids are above 100, that puts you at more risk of having a stillbirth. So what do we do about cholestasis? We treat the mothers. So the two arms of treatment reduce your symptoms, and that's mostly itch. So some women can describe the itch as just being mild, it comes and goes, it's not too much of a problem, right through to I cannot sleep, this itch is terrible. So we treat the itch and we protect your baby, of course. Treatment is often with a drug called Urso. It's got a really long name, which I'll stumble over, so we'll call it Urso for today. And that helps clear out the bile acids. It helps with the itch, but unfortunately it doesn't necessarily help with reducing the risk of stillbirth. There are a number of other medications, but fortunately cholestasis tends to happen late in a pregnancy. So often we start with the Urso, get you through to a reasonable gestation for delivery, and then have your baby. We do know that for cholestasis, some practitioners will deliver your baby anywhere from 36 or 37 weeks. Now this is a real contentious point. We've got the risks of stillbirth, the worry of mum, the discomfort of mum as well. We don't have a lot of good evidence to guide us when it's best to have a baby with cholestasis, but that is a conversation that you need to have with your care provider. So cholestasis, not everyone gets it, but when you do get it, it can be bad for you and it can be bad for your baby. A VBAC is a complex conversation. I really recommend that you have that conversation early with your care provider. Start gathering your facts and your information. Probably the key thing that we need to know is, why did you have your first cesarean section? And that's one of the key predictive features for which is the best way to have your baby this time. If women are setting out to have a VBAC, so a vaginal birth after a previous cesarean section, about 3/4 of those women will be successful and have a vaginal birth. Of those women that are successful, we know that the things that help us predict their success rate are if they've had a previous vaginal birth. So for instance, if this is your third baby, you've had a vaginal birth and then a Caesar, then that's a really good marker for success for a VBAC in this pregnancy. If we can find out what the indication was for your previous Caesar, so was it that your baby was in the wrong position? Was it a breech baby? If that's the case, then your success rate of having a VBAC is also higher as well. We know that if women are aiming for a VBAC, that a spontaneous onset of labour is going to give you a good predictor as well as to whether you'll be successful in having a VBAC. We know that if your cervix is more ready as well, then you're more likely to have a successful VBAC. If you've had an uncomplicated pregnancy, also better success. So we've dealt with the things that might give us a successful VBAC. What about that 1/4 of the women who are trying for a VBAC that end up with an emergency Caesar? Who are those women? So if you've had a Caesar for a previous obstructed labour, then you're more likely to require an emergency Caesar in your attempt for a VBAC. If we have to induce you, same story. We also know that women with a complicated pregnancy are more likely not to get to the VBAC. So things like high blood pressure, obesity, advanced maternal age, if your baby's large, or if you've got diabetes of pregnancy as well. So those are things that can predict that you're less likely to see for a VBAC. We also want to think about the maternal benefits of having a VBAC. So we know that it decreases maternal mortality. Now, mortality in Australia, thankfully, is a really low event. So we're talking about tiny numbers here. We do know that VBAC supports a increased breastfeeding rate, which is great for babies. Maternal risks are, the main one is that you end up trying for vaginal birth and end up with an emergency Caesar. So this can be one of those situations that you wish you avoid. If your options are to either have a beautiful normal vaginal birth, great. You might find that your next best option is actually then to have a planned Caesar. So it's controlled and planned, and you know when it's happening and what the likely outcomes are. The other thing that we think about for maternal risks and also fetal risks are the risk of uterine rupture. Now, this doesn't happen that often. It's only 0.5% of those women who are having a VBAC have a uterine rupture. However, that can be catastrophic for your baby and also for you. The other thing that we think about in terms of maternal risks are if you do get to have a vaginal birth, there is obviously the risk of having perineal or pelvic floor trauma as well, and that can have lifelong consequences for some women. When we think about the benefits for baby, there are many benefits for a vaginal birth, mostly related to breastfeeding, good outcomes in terms of neonatal mortality and morbidity, and the other thing that we think about, and we still need to learn a lot more about, is the microbiome that the baby picks up, so the bugs that the baby picks up as the baby comes out through the vagina, and that's a really intriguing area that we're learning a lot more about at the moment. If we think about the risks for a baby, if the mum is having a VBAC, as I touched on previously, there's a slightly increased risk of perinatal mortality for the baby. Now, again, we're talking about small numbers here, but the difference between having a repeat caesarean section versus a VBAC does give you a little bit more perinatal mortality. The other one that's interesting to note is that your stillbirth rate increases. Again, small numbers, but it's related to women waiting for spontaneous labour. So the longer you wait for a spontaneous labour, which we know is the better option for a woman trying for a VBAC, the increased chance there is of stillbirth. The final thing that we touch on as well is that there is always a risk of brain injury for babies with a vaginal birth. This is slightly less with a Caesar birth, but again, we're talking about small numbers. I hope you found that helpful, considering the VBAC versus a repeat elective caesarean section. There's a really good guideline that you can find on the internet, which is the Queensland guideline regarding VBAC. It's got a lot of this information in it, and if you want to, you can have a read of it. It's open access. Thank you.